stuff. It's a great meeting. I'm sure you guys are having a great time. You know, it's 10:30 at night here. We have a couple of wires in this guy's coronary, so thanks for coming to us a few minutes earlier than anticipated. I'm Ashish Pershad, and I'm going to introduce my team. Okay.
Thank you for bringing your team in so late.
Can you guys hear me? Can you guys hear me?
Yes, we can hear you well. We can see you well.
Beautiful. So to my right is Randy. To his right is Leah. And to his right is, her right is David. And behind is Belia, Candace, and Roger. Obviously, this is unusual to do an elective case on a Saturday night at 10:30. So we're grateful and appreciative of all of their efforts to come in here. And we have a great case. And without much ado, I'm going to just go straight to the PowerPoint. Does that sound reasonable?
Sounds great.
All right, super. So we're in Arizona. And this is a 68-year-old gentleman. He's got angina, typically with exertion, escalating. He's on 2 anti-anginal agents. He's got this weird ankylosing spondylitis that kind of comes into play here because of some weird angles and scoliosis of the spine. LV renal function normal. He's also got some degenerative MR. I saw that Seibel did a nice case earlier on, so hopefully we'll have to deal with that if his symptoms of MR don't get progressively worse. Probably not ready yet. Next. So his angiogram, as you can see. Can you guys see the angiogram well?
We can, yep. We see
excellent.
The left panel.
So to the left panel, you see this calcific lesion. That's a bifurcated LED diagonal lesion. You can also see some collaterals to the right. The circ looks okay. Play the right panel, please. That's the spider shot. Next shot. Next slide, please. Yeah, so we did a DK crush about maybe a month ago. Fixed the LED diagonal with imaging, and the results look reasonable. Next slide on the right. So the target today is the right coronary artery. Next slide. And this was the image of the right. So it's a pretty, it's a codominant right coronary with a pretty decent sized PDA, heavily calcified. Not really a shepherd's crook, but a pretty decent angulation pointing up, and then some diffuse proximal disease, mid-segment occlusion right after the marginal, and then maybe a 30-40 millimeter occlusion, at least based on that image, that fills the distal PDA and a relatively small PL segment. Is that agreeable to everybody as far as the interpretation of the angiogram, or any comments, questions?
I think that looks reasonable. We look forward to seeing the duals when you have them, so we can sort of discuss strategies.
Yeah, so the duals, I'll show them to you right now. So I'll start with our first dual. Actually, sorry, let's get forward one more. Yeah, so this is our first dual. It's an eleocranial. You can see that there's a silhouette of calcium that basically tram tracks the right coronary that deceptively looks like there's actually contrast opacification, but it's actually not. The artery is got a non-ambiguous cap that sort of ends right at that marginal. And then there's that long 30 millimeter or maybe longer segment of occlusion before the PDAs. Yeah. Okay. Let's play that one more time.
Any other views for a good intervention of collaterals?
Have you got an RAO? I'll hand the
so we'll show you. So what view? So before we get started, yeah, sure. So let's just go to the. I'll show you what we've done so far. So this is an epicranial that looks at the RAO, that looks at the shot of the septal. So the first septal is jailed from the stent in the LED diag, and then. This is the next shot. This is a eleocranial. And I'll stop here. So what would the panel suggest? How do we go about doing this? And what would be the strategy? Sanjog, and then I'll have the rest of the guys comment as well.
Yeah, so
just a quick comment on the setup. Just a quick comment on the setup. I mean, you know, we're not... I went radial last time, and his radial pulse today is not that great, so we've decided to go bifemoral. Typically, we'll have a femoral and radial approach. So we have 7s and 6s in the groin, both sides, a 90 cm guide for the contralateral injection in anticipation if we have to go retrograde, and then a 7 French guide on the right. Usual setup antegrade involves a guide extension, turnpike spiral, and a workhorse wire up to the cap. And on the left panel, usually we'll keep a marker wire in the LED.
Great.
Or a safety wire in the LED.
Right? Yeah.
Yeah, exactly. Yeah, exactly. So that's the plan. So what
dominant
would the
RCA,
audience?
non-ambiguous proximal cap, 40 millimeter occlusion, lots of calcium. Looks like interventional collaterals to a tortuous retrograde PDA from septals that arise in various places across the LED. Dr. Suryaprakash, what are your thoughts, or Dr. Jayada, what are your thoughts on
here most
so
important?
before.
You have to prepare anti-grade because it's a calcific segment. You have to prepare anti-grade. It is very difficult to cross anti-grade wire escalation, de-escalation, and you have to complete by means of retrograde. So anti-grade preparation and then retrograde cross is the better. And because of the calcium, maybe sometimes the wire passage become a little bit difficult. You may use knuckles also sometimes in this case, especially retrograde knuckles to fracture the calcium so that you can complete the procedure.
Doctor?
Any comments about which septal, whether you can use the jail septal, so I think I don't disagree. This is going to be just from the virtue of the large amount of calcium and the vessel being fairly tortuous that it's going to end up being requiring bilateral knuckles. We may get lucky antegrade, but I doubt that that's going to happen. And so probably will require bilateral knuckles and then end up with the retrograde reverse card as the strategy that's going to be.
Dr. Kaiser Nasrullah?
Yeah.
What are your thoughts about retrograde versus antegrade, and are you going to approach this with proximal septal through?
So Sanjo, before you guys get
the
everybody going, can I just work and talk at the same time so we're not eating up time? So
please do.
I'll tell you what we've done so far. So just so you know, so what I did was, of course, we've got our setup, and then what I done is basically was able to, through that invisible septal, which is not exactly the septal that I would have chosen, but using septal surfing and whatever else we usually do, and was able to, with pretty simple Xi'an black manipulation, was able to get into the PDA, and I am currently in that PDA distally. And I will just verify that to you guys by showing you here. And you can see that the wire moves pretty freely. Actually, it's come back a little bit, but it's, trust me, is in the PDA, and there it is, and I am in the PDA. And I'm going to advance my microcatheter up to the distal right coronary. On the right, on the other side, I have a run through and a turnpike spiral. And you can see that I'm just going to advance the run through into the proximal right up to the cap.
So that's interesting. It looks like it's it's not as long as we thought it was.
Yep.
Right? Given how far your retrograde Xi'an black has come up, which is nice because your connection is going to be along a more straight part of the vessel now, as opposed to.
Yep.
But what is the wire, retrograde wire?
The retrograde wire is a Xi'an black.
Just a Xi'an black right now. He's just crossed.
Yeah.
So would you prefer the Xi'an black or filter XT R wire for this crossing the septals?
No, I think we've been using the Xi'an black as the go-to.
It's
hardly
interesting.
ever.
There is a differences in philosophies that I have observed going back and forth here, where I think the Xi'an black is, generally speaking, in North America, our wire of choice, or the regular Xi'an, rarely the Shuo for the epicardials, but there are the sort of last-ditch effort fielder XTRs that people will use here to cross, which personally I don't, but there's some success, particularly from the Japanese operators who come and do a lot of the retrograde education.
Yeah, so if you guys can watch my hands, I'm sort of like, it's a tortuous tortuous PDA, and I'm sort of making my way gently using the turnpike LP through the, with clocking clockwise and just counterclockwise and just advancing this through the.
That was very nice, because I don't see your guide pushing out all that much either, which I guess tells us though there's tortuosity. You know those invisible septals, sometimes you can't see them, but they are decent sized channels. If that was intramyocardial, it would not have crossed like that.
Correct. And then what I like to do at this point, I don't know what you think about that, Sanjog, is basically I take my Xi'an out and I'll take a tip injection with a medallion retrograde just to get an understanding of the lay of the land and also to do like a reverse or a retrograde
Maybe
Carlino
retrograde
just to
Carlino,
soften it.
I think
Yes,
there's
exactly.
about no
Just sort
downside
of,
to doing that so long as you're not at a
Yeah.
branch point. So, Dr.
yeah,
Tiwari,
and
what
exactly.
are your
And the goal
thoughts
here is to
on-
anyway do knuckling, so it doesn't matter. So
Dr.
even
Tiwari,
if
what
I
are
do
your
inject-
thoughts on next wire, next approach?
What is the preferred wire? Yeah, exactly. Retrograde.
I think you are, if somehow with a
There you
heavy
go.
calcified
Yeah.
RCA at the bend where you are moving forward, if you are not
About
able to
200.
move forward, you can try the Fielder XT. This is what I will prefer to start with in this long segment, heavy calcified.
Did you guys see that shot? So
Yeah,
it's
we
already
did,
dissected.
we did. Wow, that's
yeah,
a
it's
lot of
dissected
calcium.
and,
And
yeah,
any-
and it's calcified. I'm going to just
any-
take a Pilot 200.
Yeah, I was just going to
and-
say,
and
so
get
I
it
would
to the
not,
captain.
I would not take a Fielder XT here. This is something where you're going to knuckle and you're going to need something with some guts to it.
I think
So Pilot 200, Raider, Mongo, even Mongo ES if you
Yes,
have to,
yes.
come retrograde hard,
Yes,
and then
yes.
do the
Yeah.
same thing antegrade and complete your reverse cart. This is, I mean,
Because I just don't see the Fielder XT will be laughed at by the
yeah,
elderly.
exactly. It's just going to end up getting pushed out over and over.
Yeah, exactly.
You know. So yeah,
That
that's
is
what we
the
were saying.
Gladius
So
Mango.
Mongo is that's the MG14 Gladius
Yeah,
is what they call it on this side of the world. In North America, it's euphemistically referred to as the Mongo, because Bill Lombardi helped to design it, and that's his nickname. So nice retrograde sort of
Yeah.
chunked up wire. Is that a Pilot 200, Ashish?
It's a Pilot 200, Sanjog.
Yeah. So the other benefit of the Pilot 200, I guess, if you're coming retrograde with a knuckle, if you had ambiguity, is that the knuckle will be a decent size.
Yeah.
So it sort of helps resolve the ambiguity. Though here, I think you know exactly where you're going, with multiple different
Dr.
fluoroscopic
Sanjog,
markers.
Gladius will produce small knuckles compared to Pilot, which produce
Comparatively,
large
yes.
knuckles.
Yes, yes.
So that is preferred actual.
I mean, I think in this vessel, it's a huge vessel. So honestly speaking, you're going to need a big balloon to complete a reverse cart. Doesn't matter if you use a Pilot 200 or a Raider or a Gladius, though
Give me
my
a Pilot
preferred
antegrade.
retrograde knuckle wire is almost always a Gladius. I think it's
That is
just
safe
so
also.
well
Retrograde
designed.
knuckles are safe.
It's safe. I guess the only headache is with that one, because the knuckle is so tight, you can catch a side branch, and you will blow out the side of a side branch. So if you talk to people like Bill Nicholson, you know, they'll say that they typically use Fielder XT for their knuckles now because they're multi sort of layered, very large knuckles, and the likelihood of going out a side branch is very low. I think it's a philosophical thing. As long as you know where you're going, there aren't huge side branches in the middle, the risk does go down. So Dr. Varghese, are you going to take a similar sort of Pilot 200 type wire antegrade? Are you going to go with something a little bit more penetrative?
Yeah, probably.
uh,
I mean, I think probably take a Pilot type wire, make a loop from both, and like Sir said, probably a reverse cart.
So I think
As we talk about side branches, and there we go.
yeah.
So look at
Just
that
making it
pushback.
fold.
Man, that's nasty calcium. That's exactly what we were thinking would happen, though, yeah? That's probably it. It's a Pilot 200 antegrade too?
Yep.
Yeah. Yeah. I think the key here is
And-
the task that we're trying to solve, the task that we're trying to perform is penetration into the subintimal space, right? And the wire properties that are necessary to do that are a decent sized core with some pushability, a polymer jacketed wire that will knuckle easily, so Pilot 200 would do that nicely. Even a Fielder XT could do that, though I think I'm in agreement with Ashish here in that I think the Fielder XT is going to get laughed at with the amount of calcium that there is.
So I'm actually going to get my trap liner in a little bit.
Yeah, yeah.
So I'm going to blow up the trap liner balloon in the proximal right, take my microcatheter back, get like a 3-5 balloon in the very proximal right, so I can actually prevent the hematoma and all the dissection
Yeah,
antegrade. So that's what I'm working on next. So
yeah, he's got a turnpike spiral antegrade, and a
Yeah.
retrograde is a turnpike LP150. Though, you know, the spiral with this amount of calcium, it's great when you manage to get it into the, you know, the intraplaque
Yeah,
segment.
but it's hard to make
But it's
the
hard to
first
make
entry.
that transition past the proximal cap, right? That's
also
a-
sometimes, you know, I've noticed though the other ones, you potentially could lose the tip.
Yeah.
in the calcium.
Yeah. Rarely
So
that's
that's
an issue.
why I'm a little hesitant to
Though that's, I mean, I
go with them
found
up
tip
front.
loss is more common with the
Caravel.
lower profile Corsair catheters than,
Yeah. Yeah.
than the turnpikes because of the
Yeah,
braiding that they
Caravel
have.
and even,
yeah.
yeah,
Caravel is a
that's
particular
classic.
culprit for that.
worst. Yeah.
I guess, this
Anything
one,
that you-
looking at this, I'm wondering if you're going to need a power knuckle or even
Might be.
even a
base.
base in order to get into the subintimal
Yeah.
space, right?
Yeah,
Because that's
yeah.
just a wall in front of you.
Yeah.
And in fact, the base might be a very nice dual-purpose technique here because you may create a nice dissection in the mid RCA. So if you have difficulties getting in antegrade into the SI,
this
your
smaller,
retrograde
shorter
wire
bit.
may be able to come up into the same segment, right? Dr.
Just
Thibar.
getting a shorter balloon. The first
What-
balloon was a little
what's
bit.
if you fail with the pilot 200, what's the next wire you are thinking to maneuver it? Because
So the question is, Ashish, if you knuckle up with a Pilot 200, presumably
Yeah.
you're going to be in reverse cart position. If you manage to do that in
Yeah.
antegrade and retrograde, what's your reverse cart wire in the setting of heavy calcium?
Usually a Gaia 3,
Gaia 3.
or something like that. Yeah.
Anybody have any other approaches in terms of sort of retrograde or reverse cart wire? Is everybody with a penetrative navigation directed wire or?
Once already
Is this a 3.5?
better
Yeah, good.
you gain a high tip load that is Gaia next.
To tell you the truth, I don't know. This maybe is
Yeah.
just my approach to these things. Sometimes when I've got these heavy amounts of
Go.
calcification, and you've got penetrative wires like Gaias that are not going to be particularly stiff in both axes, I don't mess with those. I will take a larger balloon within the segment. I will crunch up whatever the plaque is, and then you use a nice safe wire like a new Pilot 200,
Wow.
new Mongo, to make that connection. And if that doesn't work, then you go to something that's properly penetrative and easily directed. So Hornet 14, Confianza Pro 12, get into the antegrade trap liner, advance your microcatheter, and just externalize.
Did you see that, Sanjog? I was able to get the guide liner, trap liner down, past all that, and I'm now sort of in the
Yeah, yeah. For
Vessel.
reverse cut to puncture, sometimes I would prefer Conquest Pro 9 or 820 if it's very hard. That's just inflating the balloon and aiming
Go up.
that thing.
That's an interesting discussion. So do you
Yeah.
have any 9-gram tip
Perfect.
wires on your shelf?
For me, no.
Me neither. I don't really understand the usage case for those. Because
take
the Gaia third is going to give
Trap
you a
liner,
tip
I mean the
load in the 6
microback.
range, right? And so it's a very gentle step up going from 6 to 9.
And then I'll take a
If
Mongo.
you're actually going to go to a penetrative wire, in our lab anyway, we tried to get rid of all of the 9-gram tip wires because we find that they're sort of in between. It's
Only
like
Gaia next
it's
to
like
fourth is there, but it's not available in India.
Yeah, we don't have
10
that.
grams tip load.
We don't have that in North America either, right? And so that's the point at which you go to a Hornet 14, right? Or you go to a Confianza Pro 12 or one of these other penetrative wires where it's almost one-to-one torque control, lots of penetrative power, but you're using it only to cross between, your connection point and your trap liner, so you're not actually wiring with the wire as it's
Take the
not safe
Mongo.
to do so.
So
So
now I
Ashish,
have,
any consideration of maybe
go ahead.
putting a second wire through that trap liner before you put that down, thinking you might need base?
I'm going to try the Mongo, and then if that doesn't work, then do the.
Or an
try that,
antegrade
yeah.
Carlino and then the Mongo, right?
Yeah. Can do that too.
Because you've got a little side branch there that you keep getting into. So I think the
Yeah.
antegrade Carlino might give you both definition of exactly where that is and, and
Good.
disrupt some
I'm
of the
good with
tissue.
that. Yeah.
Yeah.
I'm okay with that. Here we go. So just
Any power knuckle?
gentle injection.
That's Sanjay Kalra. Any power knuckle?
I think we were just discussing that, right? As a power knuckle or a base, for which he'd need a second wire, but I think he's confident that with an antegrade Carlino, he'll be able to disrupt enough to get going. Yeah, so it's a wall.
Yeah, but I'm there. I think I'm in a
you're right at
reasonable
the proximal
spot.
cap. I just think
Yeah.
it will be interesting. I think the easiest point to enter this is going to be a little bit back from where your tip is.
Yep. I'm going to back out a
Because
little
it's
bit
just
and
going
then
to
just
keep on banging against that front door.
concrete. Yeah.
Yeah.
I think the problem with it, even it's really not a.
Hey, Ajay, how are you?
Hey, Ashish, it's great to see you. I was just
Yeah,
gonna
how's it going? Good.
It's
Yes,
great. I was just, the problem is that in theory you can try Carlino, but if you're not in the subintimal space, it's just an injection of the vessel. And I think what's happening here is you have to get subintimal somehow, and what he's trying to do is do that either with knuckles. Now, so there you
Like
go.
so.
Nice.
So that
was
worked.
awesome.
But
Can you floor store that? That was nice.
without that, you have to solve the problem somehow, and that is either penetrate, de-escalate, or then do base or do scratch and go or something. But thankfully, in this case, it broke through, and now you don't have to worry about that.
That was great. Although you're, I mean, it's
quite far away.
It's it's also very tortuous, right, Ashish? So it's harder to tell exactly how far that is.
Yeah.
Right? Like it's that you may be right on a bend there.
It's so crazy. I think I'm in the vessel.
I think you're there. Nice.
I know, but I think my wire distally is in the true lumen. It sounds crazy.
Did you just go antegrade true?
It seems.
I think so. It feels like it.
True.
That's what I'm going to take a retro test and confirm. It feels really weird.
That's adorable.
Yeah.
It seems intraplug. Anti-grade.
Maybe advance the wire while contrast is filling so you can see.
There you go.
Yeah, you're there, man. Well done.
Yeah, yeah. I think that's. I'll just verify it. I'm not in. I'll just advance. Yeah,
I would pull the retro microcatheter back so you can see a little, because it's.
And even maybe just get a workhorse down to just make sure I can get that. Yeah. So.
I guess the only jeopardy in taking the workhorse approach now is that means if you're wrong, you're going to go past the bifurcation with your microcatheter to get the workhorse there. Right?
Yeah.
Which is why, I mean, you've got a nice secure retrograde knuckle. You've got long ways. Just pull your retrograde back and then use whatever wire you're in under direct visualization to wire antegrade down the PDA, and then you know you're there and you're there.
Yeah.
Just don't lose your retrograde wire there.
No, I'm not. I'm just pushing it. Yep.
Yeah. Yeah, I don't think that's...
It really feels free. It feels free.
It looks pretty good. Just to maybe take that retrograde now and, satisfy everyone's curiosity, but I think you're there.
Yeah. Retro injection, Inject.
Yeah.
That looks pretty good. I'm not able to visualize it as well.
Yeah, it's
because
not.
I think a little distant.
I can see you can see the filling just beyond the curve of the microcatheter, but it is a challenge to see it for sure.
I'm not convinced. I don't know for sure, but it sure has that tactile feel like I am. I'm going to just...
Can you, I think I saw you enter a branch. So are you able to enter a couple of different branches off the PDA? Just gently with that wire. It's not a...
Let me take a first shot and see how it looks though. Let me just go back and play this and see how the...
Yeah, and I think the other way to do this is to change it, because there's so much tortuosity down there, is to do an RAO and see, because you just want to be sure.
Because the other option...
So this is the LAO cranial. This was the way it looked before. So let me just see how it's... There are not that many branches except one that comes towards me.
The other option, Ashish, was you remember where the Pilot 200 came out and looked like it went true? It was still within the distal RCA. So you can bring your microcatheter down into the distal RCA, then switch for your workhorse. So you don't cross the distal bifurcation. You don't jeopardize that.
No, that's in. That really is.
That looks. It sure looks true. But if you really wanted to be sure and couldn't see, you bring your microcatheter proximal to the distal bifurcation and just swap for the workhorse.
No, I feel
which you're
very
going to need
confident.
anyway.
I feel very confident in that, man.
Yeah, you're tracking right along the vessel, and you're also not bending as you go, right? You're not spinning the Pilot 200.
Nope.
You're not drilling. It's just kind of
proceeding. Just going. This is the Mongo,
Yeah. So even more, right? So a Mongo has a core stopping back of the tip. That Mongo, if you're subintimal, will knuckle on you fairly quickly.
Yeah, okay.
Nice.
We're past the bifurcation at this point. I think I'll try a workhorse here and see what happens.
Agree. And do you find when you spin the spiral, which is, so the Turnpike spiral has been relatively recently introduced here in India. It's a very, very effective antegrade microcatheter. Do you find that when you're screwing the spiral in, you turn slower than you do with some of the other microcatheters?
No, not really. So I'm getting brisk blood return. Not that it means anything, but
it sure looks good.
I'm getting almost like it's almost filling my microcatheter hub before I even. Yeah. So
that sure looks good.
I'm just going to get this down there, and then ultimately I think I'm going to need to image and roto, so we can.
Well, we've got a Kiko sitting here on the panel as well, so that image.
Oh my God, I
think
so
we
lucky.
all want that image.
Yeah.
Yeah, that looks pretty good, man.
Okay.
Is it going?
All right. Yeah, it's going past. It's actually not much to go. That's really where it is. So.
Yeah. Huh.
Behaving a little.
Yee.
It's tortuous there too.
It is.
So.
What's your workhorse? Is it Xi'an Blue?
It's a run through.
Run through. Okay. Because that's the other thing, right? Is the run through is a very floppy tip. So if you're hitting tortuous segments and plaque, you will collapse on the tip versus like a Xi'an Blue where it's going to be a little bit more directable.
I'm just gonna bring my micro back and see what it looks like. Take a retro test again and see if it helps. Okay. All right, let's take a retro test. Inject.
It is very difficult. So what it tells us as well is that the dominant septal through which you're filling is probably plugged by the microcatheter.
Yeah.
Right? Your pressure heads are not lighting up because that PDA is big.
Yeah, let me try to change the angle and then see if I can.
You're sort of in an LAO view now, right?
Yeah. How about going RAO cranial?
Yeah. Yeah, or even just straight RAO, where you see the septals cascade down right into the PDA.
Yeah.
You might see the distal end of the PDA that way, because you're already in it.
I think this is a good view.
This
is a great shot. You're right.
Yeah, this is
a great shot. Yeah. All right. Let's take a semi. Yeah. Jack.
There, okay. But you know, when you've got the cine going and the contrast is coming up,
I'm going to take
while
a
that's
picture.
full,
Yeah.
right?
That's what I'm going to do. Right. Yeah. Yeah. See. Yeah. Okay. Cine.
That
just feels like it's gritty. Doesn't look right, yeah?
That doesn't look
so
as
maybe
good.
it's fine. Yeah, all right, so it's fine. So we have retrograde wire.
You have retrograde access in the true lumen.
Yeah, so we're just going to do reverse
card. Just take your retrograde wire
that?
and let's just do reverse card.
Yeah, exactly. Let's not screw around. Yeah, I agree.
But I think therein lies the case for why you have to be sure.
Right. Yeah.
Looks like subintimal.
Yeah, it looks subintimal, correct.
Interesting. Look at that.
Yeah.
That's just a Xi'an black, right? Oh, no, that's your Pilot 200.
No, that's a retrograde wire.
Yeah, that's your retrograde Pilot. Okay.
Yeah. Okay.
Yeah.
I'll just get my retrograde gear to a place where the knuckles are, where the micros are touching, and then we should be in business.
So lots of calcium. What's your sort of reverse cart strategy going to be here? Where and
straight part of the vessel. That's going to be the first thing.
Yeah. So right about where you are with your retrograde microcatheter now, yeah?
Yeah, right, exactly.
Yeah.
Exactly.
Well, either above the bend or below the bend, but not at the bend, right? Yeah.
Correct. Yeah. And then be flexible if it doesn't work.
Yeah.
There.
Would you track your trap liner down at all? I admit,
I'm going
like,
to track.
sometimes
Come back to that LAO-cranial view.
Sometimes I'll track my trap liner down pretty distally in these situations, just to make that.
Yeah, it's already. I still have pressure.
It's
where
quite a
I
ways
am.
down. Yeah.
So, yeah.
But I mean, I'll track it down not to block off pressure as much as, because you don't have a ton of branches you're protecting there. It's more just to make your reverse cart life easier.
Yeah. Okay, super. Come back to that RAO here.
Nice. Oh, that looks nice and close, yeah?
Yeah, that's the spot, I think. Yeah, super.
I would be very careful, though, to make sure you're well proximal to the bifurcation.
Yeah, I think I am. The PDA is actually, I looked at it in relation to the spine, and I think I'm okay.
That's good. I think you hit that antegrade crossspin true. You would have disobeyed all of the rules that we worked so hard to establish.
I know, seriously, yeah.
Isn't that?
Here, can we de-escalate to pilot 50 so that it will, whether false or true, you can see?
Well, I think he's committed to reverse cart now. The question was, can you just change over to a pilot 50? But I think at this point we're committed to reverse cart, so we're just going to do with, you know, you've got your knuckles up now. He will be switching wires to make the connection, I'm sure. But, you know, and
I'll take a 3.0 balloon, 3.030 balloon.
Yeah. Right, because he's going to end up stenting that segment anyway. So I guess that the comment was 3.030. That's a pretty long balloon, but that
but the whole thing
segment's
is
gonna be
diseased.
dissected
Yeah,
anyway,
yeah.
right?
This one.
You think it's going to be bigger than 3.0, Ashish?
It could be.
I think
3.5
it's
is
going to
kind
be
of what
bigger.
I thought
Like,
based on the
you're gonna
knuckle
need a
size.
3.5.
Yeah, but I wasn't sure I'll be able to. We'll see how easily this goes down there. That's why.
Any use of anybody has experience using Wolverine to facilitate destruction of the tissue between the antegrade retrograde wires? Does anybody have comfort or experience doing that? So admittedly, I've done that a bunch of times. I have not. Yeah, I've never perforated. Having said that, you do undersize, and for what it's worth, I don't find it has been all that helpful. Right, and I think it just speaks to the mechanism of action of some of these cutting balloons where ductile materials will bend, brittle materials will crack, right? And that's why they don't do anything to normal tissue, but within calcium they really do split things. Dr. Tiwai.
I have a couple of cases last month that Wolverine get burst, you know, with 2.5, even such a heavy calcium.
Is your balloon tracking? Is it tough to get it down?
Yeah, it went down. I was already down. I'm just getting the trap liner further down. Balloon's down. Yeah. Go up.
Okay.
Down. Perfect.
Nice.
Give another inflation here. Go up. Down. I'm advancing my trap liner. It won't go much further. That's fine. You leave the balloon there. Okay. Taking my retrograde wire back.
Oh, up you go. Yeah?
No.
This is that bit about, trap liner down as far as you can to make your reverse cart life easier.
Yeah.
It's tough because you're coming around a bend. There you go. You got it now, right? Yeah.
Yeah.
Nice job.
Laura, save that. Yeah, that's it. Yeah. Thanks, guys. That was great. Yeah.
That's great.
Okay.
That was your Pilot 200 that you had retrograde, right?
Yeah, that was a dinged up Pilot 200, not even just a Pilot 200.
It's the dinged up Pilot, right? No, but that often works, doesn't it? Even the Mongo, it often works, right? Because you've just got a decent sized space, and if you make the right connection, you're done.
Yeah, I'm just going to manage my retrograde guide here a little bit. Bending to back out, getting my microcatheter into my...
Same pilot.
Yeah, same Pilot.
Getting my microcatheter into my
And so, Dr.
trap liner, and then I'm going to R3.
Do you have an
RG.
externalization wire preference? Are you an R350 guy? Are you an RG3? Do you have a particular reason why to use which one when?
Yeah, will
usually
you
it's
give
an
me my
RG300, that 330 is the one which we use normally. I mean,
32
length
minutes? That's a lot of
That's the
time.
one which is commonly available. That's the main reason.
Anybody else have any other preferences? RG3 all across? I'm an R350 kind of guy, to be honest. I like the nitinol, particularly in these larger main vessels. I think the RG3, for me anyway, I prefer that wire in more tortuous epicardials because of the ability for the non-kinking nitinol to create a bunch of pseudostenosis across big dominant epicardials.
So we're going with
that's
the,
just my
we, like you, Sanjog, we have the R350. So the R350 is what? It's a little bit better body. And
Yeah, it's got body to it, right?
Yeah,
The other nice thing is, Ashish, as you will put your externalization wire through, you're going to put that out. What's your process at this point to
show the
get
guide,
your-
you mean, at the
to
other
get-
side?
to get your wire out and do you do the disconnect the TUI and put the wire through?
I just clamp it proximally and then
So-
right here, and
so-
then I just, yeah.
One,
Go ahead.
Arun Kalyanasundaram is joining us as well. Ashish, Arun says hi.
Oh, hey, Special K, how are you doing?
So one interesting approach is to pull the trap liner back so it's sticking out from your antegrade guide. And what it ends up doing is filtering your retrograde wire right out through the trap liner and into the world without having to clamp the antegrade guide.
Yeah.
I picked that up from
Yeah.
Bilal Iqbal recently, and it's a peripheral trick, right? That I'm sure you're very familiar with
Yeah.
when you're sort of sheath and sheath.
It's good, but he fought to get the trap liner where it is, and I mean, there are other ways.
Yeah,
The
exactly.
the
Thanks,
clamping
Ajay.
can work, so come on. I mean, everybody likes tricks, but the position's so good right now.
Thanks, Ajay.
I
wasn't doing that.
Oh, ye of little faith. You're going to have to take that out in order to get an IVUS in anyway. So you got to take it out. You're going to have to balloon it, take it out, and probably rota through it, right? So that's coming out one way or another.
But not now. I mean, he's good now.
Oh, ye of little faith. He's externalized. He has a fellow-proof rail right now.
No, we've done it too, but I just think that the problem is in this space and in general in complex PCI, everybody's enamored by tricks.
Yeah.
And many times tricks are good. Sometimes they become dominant and they should be used, and other times,
No, for sure. It's all good points.
I mean, it's style. Those are style points, right? I mean, ultimately, I don't think.
Yeah, I mean, I do it the same way you do. I just this is something I saw recently, and I thought that was kind of cool.
No, it's good. It's always good to have good ideas and learn new things. I'm not opposed to that. I just think that. All right, so I'm going to just take this antegrade stuff out. I'm going to just back my retrograde wire, retrograde guide back. I mean, retrograde microcatheter back, and we'll get an IVUS down. Yeah.
And how
Watch
do
it,
you?
my guide.
I see you're controlling your retrograde guide carefully as well, right? Making sure that you don't.
Yeah,
bang it.
just backing it out a little bit. That way you don't have to worry about it. There you go. I'm in the PDA here. All right.
Nice.
So we have the poor man's IVUS, not what you're going to see with at Columbia with 60 megahertz and with AI-based imaging that,
That's okay, we have-
Kiko so
we have a
elegantly
Kiko.
shows over. That no, but that Kiko
Are
so
you
elegant.
telling
the
us you're
CTO
going to
summit.
use the volcano? Is that what you're saying? Because not even a Kiko can overcome the limitations of that device.
I know.
But you also feel comfortable it'll cross, because that's the one thing is that sometimes ballooning it first.
I think I ballooned it
I mean,
far
he
enough.
took the
Ajay.
30
I think, yeah.
through the 3030
All
right
the way
through
down, yeah,
the
yeah.
distal segment, right?
Yeah.
I can't read these.
So we have the, the 4H platform here.
Kiko's
So,
looking at your IVUS carefully now as it comes up.
yeah. Here it comes. So I'm going to get it out and extend it as far as it'll go, and then I will back my trap liner up. Okay. I'm going to back the chart liner out.
No, the thing I was talking about, the ballooning part, is down there because the wire was subintimal down there, and you want to see what
Yeah.
the distal landing zone is going to be like.
Yeah, but look at
looks
the
okay.
image
It
right
looks
now,
okay.
Ajay. Yeah, it looks like
good. It looks
we're in
good.
true lumen here, and it
I
looks like
don't
it's
know.
a nice.
To be honest, I don't know we are true lumen.
Yeah,
Seriously.
Okay. Okay. Okay.
But this was
No. This is the artifact. Yeah.
yeah, this came up
Yeah.
retrograde.
No, that's the
right, at
ring
this
down.
point.
That's the ring down. Yeah. So.
Yeah, it's okay. If you can go more to be sure we
Distally?
Yes.
More distally? Okay, I'm going to try to advance it.
This is into
has
the
to be, yeah,
PDA.
it has to
to
be,
be true
yeah.
here, right? Because you came up retrograde.
Yeah.
Sure, but
Yes.
Sure. Okay. Okay. That's I buy it. But okay, let's start. So assuming
Okay, I'm going to do the, yeah.
pull
Go
back.
ahead, sorry.
So assuming
Yeah,
this
pulling
is-
back starting now.
Go ahead. That's
Recording.
assuming this is true lumen, even though I don't see any intima yet. Okay, so that's, to me, that's the tissue. That's 9 o'clock. That's, what is that? Okay, to be honest, it's very difficult to interpret it. Okay, that's a true lumen in the 9 o'clock, and we are very sure it's subintima. Go ahead.
Yeah, which is where we did all the
that's
knuckling.
fine.
games.
That's
yeah.
perfectly fine. And
Interesting.
what?
Yeah.
No, that looks like intraplaque. That's subintima. Subintima.
Yeah.
Yeah. Go ahead. Go ahead. That's all subintima. Yeah. Still subintima. Yeah. Subintima. We are intraplaque. Actually, this is the proximal portion of the CTL.
Yeah.
Okay, that's a proximal
And this
portion.
is the proximal
Yep,
vessel.
yep.
Yeah.
Yep. That's dissected, but that's fine. This calcium was not
Yeah.
too bad compared to what we
Yeah.
thought. Not three. Okay. By the way, can you go back to the IVAS by recording the image? Okay.
Yeah, sure. Just to play it back. Yeah.
Yeah. Because I
Yeah.
may make the mistake. So go back to the very beginning. Let's go through one more time where we are.
Sure.
So the very
Okay, so here we are all the
okay.
way back there. Yeah.
So that's a true lumen. Go back. Bring back
keep pulling.
proximally.
Yeah.
That's true. Go back. Go back.
That's false.
Yes. Like 9 o'clock, you see the tissue that's collapsed true lumen. We are in the fourth
Yeah.
lumen. Do we agree?
Yeah.
Yes?
Yes,
Okay.
I think so.
Okay, go back. Okay, go back. So, but it's
Yeah,
okay
he's-
because we are true lumen in the distally, so who cares?
Yeah.
You know that tissue plane, Akiko, is it above it? We were wondering whether or not it was true or not. Is that potentially the hematoma
Yeah, no,
or
no, it's
subintimal
good.
space created by the antegrade microcatheter when it was subintimal in the first place?
Just play
Remember
that
where you
last
tried to wire in?
just the diameter, David.
Yeah,
Yeah.
that's
Right,
about.
right where that plus sign was, that's sort of false there, but you're actually the catheter's true, and that's just a tissue plane.
1, 2, 3, 3. Yeah.
To
So.
be honest, I'm very unclear this
Yeah.
picture. I need to see
Yeah,
that.
not good. Terrible image. Yeah, exactly.
But I think it's okay as long as we are confident of the distal portion, whether we are true or false,
Yeah.
it really
Yeah.
doesn't matter.
Yeah.
And importance
Yeah.
is because we are soft black.
3 or
Even
40.
we are false lumen, we pushing enough, we are no problem
Yeah.
at all. So coming back,
1 second. We're just having some issues with our PIM, as usual. David, are you able to show the images or not?
yeah, can you come?
Is it?
If impossible,
Yeah, he's
it's okay.
trying.
Okay.
He's got some configuration issues right now with the PIM, but we're working on it.
Okay, come back. Come back. Okay, it's okay.
You know what? Let's do a rerun. Just can I hit a rerun? Yeah, let's do a whole
yeah,
run again.
I think the point of this IVAS picture is next one is how to deal with the calcium. So the bunch of the place, we are subintima, and we are looking at the calcium from the subintima
Yeah.
space. And recently we evaluate what is the key of the stent expansion where you are subintima. What is important is number one, look for the subintima calcium. If that is very consistent shadowing, that's bad calcium. But number two is the vessel size. Number three is the proximal intraplaque calcium. Because that intraplaque calcium identify the true calcium, and if that is big, we expect the subintimal calcium is big. And this case, with actually big calcium, it's not 300, but enough calcium. So I do expect this stent expansion into subintima is bad. I'm not saying bad, but I think we have to be careful, otherwise we are chasing the perforation.
Yep.
Thank you.
So from a prep strategy perspective, given that you've got dense calcium through that subintimal segment, but proximally it's not that bad, and
Yeah.
Still, that's more than 180.
Yeah,
So we
yeah.
consider in the region should be larger because always the reference site is smaller than the maximal region site. So if that is, our cutoff is 180. If the proximal intraplaque or proximal to the CTO segment is larger than 180 degree calcium, we expect inside of the CTO segment should be really large and we really be careful.
Can IVL use useful in this setting for fracturing and stent expansion?
Ready, David?
so
Can I go? Can you take pictures? Yeah. All right, so Akiko, we're back. So here we are in the distal lumen. So you think a 3.0 is the appropriate vessel size
I
distally?
think so. Yeah, for sure.
Yeah, all right. So then I'm going to, so this is the true lumen here, and then here we keep going back.
so you're in the PDA there.
Yeah, exactly.
And you
then
can see
here's
little
here's
branches
the beginning
coming in
of the
on the
false lumen.
sides.
Yeah. And there's the false lumen starting right here.
Okay.
And then keep going. This is all that calcific subintimal false lumen in the knuckle segment. And then Akiko here was suggesting that we may have gone in and out, where she suggested that it might be some intraplaque wire cracking, right?
Yeah, a little bit distal, I may thought that's actually intraplaque. But anyway,
Okay.
we really couldn't understand how it is. So I think
Yeah.
this calcium is very dense. So I think
I saw
by
that,
looking from the subintimal space, I do consider this is very dense calcium. But when we measure the vessel size here, it's almost like 4, right? Our
Yeah,
cutoff is 4. If the 4 at the subintimal space, actually more likely okay expansion. So
Yeah. Okay. So basically take a 3.0 balloon, NC, then to get a 3.0 stent, and then post-dilated,
Yeah.
and then
Yeah.
proximally go with a 3.5 or a 4.0,
Yeah.
depending on how
Perfect.
things go.
Yeah.
and
Yeah, all right, sounds
importantly, your
good.
proximal is.
Sorry, go ahead.
I think that, the proximal vessel will be an assessment after we get the distal secured, right?
Where's this one? Where's this one? Oh, ready? All right. Let's test the retrograde test.
I guess it's interesting though, we look at the amount of calcium there and the upfront plan was potentially rota,
That's okay, yeah, that's
which
okay.
doesn't look like that's what you're going to need to do.
Yeah, wires come over the one. Yeah. All right. Yes, I don't think so. I agree with you. Just having a little issue with pressure, so I was just figuring out if it was the guide, but just had a little drop in pressure.
Sanjog, while they're working on it, Sanjog,
Yeah.
do you want to just
Yeah,
comment
just
on, like, okay, you have the IVIS images, right? Just for the audience, you know, part of it is
This is a 3.0.
subintimal, part of it is intraplaque, etc. You've seen the 180-degree calcium. How does the IVIS image in general help you? Kind of talked about it, specifically from a calcium standpoint. There was a question asked about IVL. What's your strategy? Like, how do you do it? We
So-
talked about no atherectomy, like rotational atherectomy necessity, like
Don't
we
put on
know.
wire.
So do you test with an NC
That's the
balloon,
wire.
cutting balloon, IVL? You have a lot of options now.
Yeah, so I mean, I think personally,
That's the problem.
with this type of an image, which in fairness is not all that detailed because of the type of IVIS that there is, we're extra plaque in a large segment of calcified vessel. You're not going to be overly
Go up.
aggressive with prep because I think, as Akiko has said, you're going to chase a perf. The key is making sure that your
Down.
distal edge and your proximal edge are well prepared,
Well, huh?
and you understand the true vessel size based on those two segments. And you don't push the subintimal segment excessively far. We're pretty comfortable
That's
with
it.
asymmetric
Yeah.
stent expansion, so long as you have a reasonable MSA. And that, I think, is what
Ready
the
with
goal
my
is here,
stent?
right? So as far as a prep strategy
Yeah.
goes,
No, 3.0,
there's
48.
nothing in
3.0.
here that's going to require IVL or really aggressive therapies within the CTO segment. Proximally, maybe, but we haven't really seen that in all that much detail yet. Yeah. And I mean, frankly, IVL in this scenario, I'm not sure it's going to be all that helpful because you've
exactly.
got
It's
a
on
very
one side.
distensible side. I think this is, the simple, straightforward strategy here is
NC balloon.
what has been taken, which is a simple long NC balloon where we observed full expansion and we move forward.
Yeah, other comment was, I do think the cutting bottom, you have to be very, very careful.
Yeah.
We are sitting
Yes,
in,
I agree. I've had some bad perforations with that.
we are sitting the adventitia, that's number one.
Here, definitely.
Yeah, number two, in terms of the stent choice, we submitted some paper. If we look into the serial OCT baseline follow-up, and if we look into the only in-stent restenosis cases, we see 30% of the cases is actually chronic stent recoil. And the important predictor of the chronic stent recoil is calcification.
Yeah, for sure.
So asymmetric stent expansion, you are stretching only one side, you are more likely causing the chronic stent recoil. That's we are going to publish. So I think this case, once we go through, I recommend not super thin strut like the, So regular stent strut, that's, yes, that's I meant.
Yeah, recoil I think is an underappreciated issue in the CTO space. We've been very concentrated on the distal vessel growing, but what we don't realize is that these long subintimal segments with dense calcification where we've effectively gone around a solid tube, there's a lot of recoil there. And I think those of us who do a lot of CTO work, we're all guilty of having pushed the stent too hard in that segment and blowing out the wall. It happens to us all, right? And so that I think the community has learned is probably a fool's errand.
Going up with a 3.5 now, approximately.
The comment here is, is IVL helpful in this scenario? In my experience with these, I don't find that because the idea
I think if
that,
an NC balloon doesn't expand, if there's other
if
evidence
an NC doesn't
of deep
expand,
calcium,
it's different, right? But if it does, what you're talking about then is fracking addressing a half of the vessel, which doesn't make a whole lot of sense to me if the other side of the vessel is principally
I'm not
distensible.
acute result. It is a chronic stent recoil. You can prevent by the IVL.
The problem is I don't think you're actually going to modify the segment of vessel that you've gone around with IVL at this point. Maybe later when there's a new intima and there's more structure on the other side, you can actually get that impulse conducted, but at this point you're just going to stretch one side of the vessel and the impulses are going to go out that side, right?
Get a 4020 NC.
That's great. What size of NC was that?
No, this was a stent.
This was
a 3.5. Now we're going up with a 4.0 NC approximately.
That's great.
Seems like everything is well expanded.
Long. Very long. Yeah. I guess the other thing, Akiko, to your point, is we don't have to, in most of these cases now, we don't have to aggressively size distally because the stent platforms are so hyper-expansible now, right? Where you can realistically take almost any modern 3.0 stent to nearly 4.0, right? Recognizing that those are third generation, fourth generation DES where the struts are thinner. And so there is that stent recoil issue.
And the other issue
Here's our 4.0 NC.
actually like the fracture things. This is very bending portion and calcium, that's really high. But we cannot
Overstitch.
Perfect.
The other thing I noticed, Ashish, is that you've taken very few pictures, which
I know, I had to do that.
is commendable, right? Like that's the point, is you're not ruining the vessel in front of you by antegrade contrast over and over. And from a retrograde perspective, you really don't need it.
What purpose does it serve?
The only thing, arguably you might make the argument for is a picture when the pressure starts to get south. Retrograde to make
and
sure
it's
you don't
actually
have an injury.
It's better now. I don't know. We think Roger's probably helped it a little bit.
We see that it's come up a little bit. I think I wonder if your retrograde guide was sitting on the aortic valve.
Might have been, but I don't. It wasn't the
or not
diastolic
retrograde.
wasn't
Sorry,
low,
your antegrade guide was sitting on the aortic valve because it's
I
backed out
don't
now, right?
think, Go up. Yeah.
Is the
Might
most
have been.
common reason I think we'll see for
The diastolic pressure
unheralded.
wasn't low though.
Yeah.
Down. Okay. I think I'm at a spot that I can at least take an antegrade puff and see what's going on. Remember to flush the guides,
Just for the audience, and just to reiterate what Sanjag had said, it's critically important when you use a dissection reentry strategy not to take pictures when you, especially antegrade, because his finishes stenting now is when he's actually testing it out.
All right, I'm going to take a cine.
You have to stent a bit more distally.
Little dissection distally, yeah. But flow is good. I think we're fine.
Yeah.
Eleocranial?
I think the issue was that your antegrade wire probably was subintimal.
Yeah, and it roughed up the distal
And it
vessel.
roughed up the
Yeah.
distal, so you're just going to have to stent past that.
Yeah, I think you
Yeah.
have to a little
Yeah.
bit like.
You're just going to have to
20
extend with
millimeter
another
more.
12 or 15 or something into the PDA, which was a nice, healthy landing zone, and
Yeah.
that's that.
This is a good view, actually, that shows it.
Okay.
Yeah. So
Everybody's saying that we need the image one more time. This start to the
interesting, interesting,
it.
interesting. So that this tells you where that antegrade wire was,
Yeah,
and
exactly.
I would not be taking any more antegrade injections because you still have a
Yeah.
track there.
Yeah. How about if I just take a 15 or an 18 millimeter stent distal
Yeah.
to that and
Yeah.
just
Yeah, that's
deploy it? Yeah.
I think that's a good idea.
Yeah. And I just take like a 3.0 or even like a 2.5 and
Yeah.
post dilate it
Yeah.
if I have to. Yeah.
Something gently.
How about a 2.5 18 and then we'll post dilate it with a 3.0 NC.
And you know, for what it's worth, when I get these sort of things, Ashish, what's your opinion on taking a just gentle 2.5 balloon inflation before you put that stent in to evacuate whatever's in that subintimal space? You've got all kinds of entries into the true lumen,
Sure.
right? You decompress the stuff that's in the subintimal space so that when your stent goes in, you're not, you don't have these big collections
Yeah.
of stuff that you're over. You get a little bit more security there.
What do you guys think of the segment in the mid right that looks?
That's we discussed. Meaning
Yeah.
this view
Yeah.
looks worse, but
Yeah.
Yeah,
the
looks
other
clearly
view
worse, yeah.
looks better.
Doesn't look
I
bad.
hope
Yeah.
because of the stand was very oval shape. It's not like
Yeah.
round shape. That's a typical
Uh-huh.
picture.
Got it. Got it. Okay.
D-shaped and expanded stent.
There was a
We're gonna
question
image
here,
again.
Ashish, about the use of cutting balloons distally
Yeah,
to deal
about-
with those subintimal hematomas.
Sorry, what was it about?
I said
Give us a
Dr.
balloon.
Kaiser Nasrullah Khan was asking the use of
Yeah.
cutting balloons in the PDA to release the hematoma.
I don't know if this is a hematoma. This is
Yeah.
a dissection.
I
if
agree,
it was a
agree. Yeah, I don't think, I think that was probably in and out from those wires. And you have exit points within the true lumen. So this is one of those things where if you gently balloon it, release whatever's in there, you stent over it, you're done.
Sure. Going up with our balloon here to just get my guideliner back in so I can.
And just
Get
for
a
that
stent
particular
distal.
question, if you're in doubt, whether it's a dissection, whether it's a hematoma, etc., I mean, we were just talking about it. The easiest thing, you
Yeah.
already have an IVUS catheter.
just look.
Put it down, take a look.
Yeah,
Confirm
100%.
before you decide on your strategy.
You're going to have to IVUS those stents anyway, right? So you're not losing time.
Get us a new balloon.
New balloon, please.
It's okay, got it. It's gone.
Which one are you taking down into the PDA there?
No, this is just a
Just- oh,
balloon
just to
to get
track
my
your drop
guideliner, drop liner down,
Got it.
yeah. To all those stents. Well. Down. Go up. Down. Get us a balloon now. A fresh 2.5 balloon. Fresh 2.5 balloon. 2.5 20 balloon.
I'm happy we came in a little bit early to you, Ashish, because we've got another 7 to 8 minutes left before
Yeah,
we have to switch
that's-
over. So I think that
I mean, yeah, this is
should be
just
plenty of time.
finishing touches. I mean,
Yeah.
I think the teaching points of the case were well illustrated and
Yeah.
demonstrated and talked upon.
Yeah.
So I'm happy that
Absolutely. Absolutely.
1 hour is good enough for
I
a
think we're
CTO
all
if
excited
it's
to
well
see your
planned, yeah.
final result, though.
Yeah. You've sort of seen most of it,
Yeah.
just a distal touch up at the end.
So what are you putting down now?
This is just a 2.5 balloon,
Yeah.
like
yeah, just
in the PDA to
open
massage it.
and massage it and open
Yeah,
up,
and then come back
decompress
in.
whatever's stuck in that.
Yeah, and then just make sure that the stent travels
Mm-hmm.
past that tortuous segment.
Nice. Yeah, that's
Yeah.
right
Well,
about there.
yeah.
Right? Gives you a nice measurement tool as well for
Yeah,
how far you're going to have to go. Just gentle,
Yeah.
gentle pressures
Yeah.
down there. And
yep. All right, I'll take a stent next.
I think he kept the pressures pretty low. There was a question about what the pressure was that you used with your 2.5. I assumed you were pretty low.
Just massage like normal, like 8.
8. Your pressure's back to very much normal now.
Yeah, exactly. I don't know what it was.
Yeah,
but
me neither.
Probably you're right. Something to do with the guide
Either
or
guide
something.
or, because I mean, what else reverses that quickly? Maybe sedation, if you got a bunch of sedation just prior.
Yeah, maybe. How's been the quality of the transmission? Has it been good?
It's been perfect.
Have you guys been able to?
Splendid.
It's been perfect. You have a room entirely focused on you. As you load that stent onto that really fun externalized wire. We've all been there too.
Yeah, which I'm struggling in the middle of the night here. Here, I got it. Yeah,
We all suffer there.
yeah. It gets worse with age, Sanjog. Wait and watch.
That's funny. Oh, look at that track so nicely.
Nice.
That's great. You could even potentially you might get some filling retrograde. So you can see your distal edge of your stent. You might.
Yeah, but I'm not going to stand beyond this, even if I need to.
As long as you're
so this
comfortable
is
of
it.
where you are. Or maybe, I guess the point I'm making is maybe you don't have to go that deep.
But I'm already sort of
Yeah,
committed based on where the previous tent is. So. Go on. Does Ajay have anything to say or add? He's quietly just watching, or is he left?
So we are covering the entry site of the distal hematoma, right?
Yeah.
So
Yeah.
I think even after this, distal looks small. It's okay because hematoma extends.
Yeah, it'll grow. Correct.
But that's
correct.
that's why he took the 2.5 balloon up front
Yeah,
as well, right? Is
because
to try to
already
decompress
cover
it.
the entry side,
Yeah.
so that's it's here.
Yeah.
And I was in the first picture in the very distal is super normal, so I think
Yeah.
it should heal.
Yeah, that's great.
Yeah, there it is. Seems like
there it
it's
is.
better. Yeah, it's better. There it is. That's
There it
the
is.
branch.
There you go.
Yeah,
There's your
yeah,
PDA.
yeah, exactly. So,
Yeah.
all right, I'm going to put the IVUS back down to look at that mid segment that the Co was talking about.
We're all excited to see what that mid segment will look like because it's such a difficult problem to solve.
Yeah.
So for the audience, I guess everybody can see what looks like under expansion in the mid segment because that's the segment where he has extra plaque and around a very calcific segment of vessel. And the question is the MSA good enough? And even if it isn't, what do you do about it?
Yeah, that's the question. What if it's not? If it's
Yeah, I
3.5,
gotta say,
then what?
You haven't, hey, you didn't sneak in a post-deal balloon on us, did you? Not yet.
On the proximal, I did,
Proximal he did.
but
the
not
suboptimal
distal.
spice. All right.
No, not all the way where that is. Nope, I have not.
I think the challenge is even if it's under, what are you
What
going
are you
to
going to do about it?
Right?
But I think if he just using the stent
wanted
balloon, we should post dilatation
Yeah.
reasonably.
Yeah.
Yeah, no, I'm going to, but I just want to make sure.
Let's see. It's going.
Another disaster there.
Hi.
Okay. Yeah, this is under, but I think.
Yeah,
Wow, that's super
Wow.
under expansion.
Very under.
yeah,
Okay, so I think
Yeah.
you should measure the even vessel to media and
yeah.
okay. You
And take 80% of that and go with
yeah,
the balloon?
Yeah.
Is that what you,
I think I expect you should be able to at least 3-0, right?
Yeah.
yeah,
Yeah.
You have
Wow.
to.
yeah,
And I mean, the RCA shouldn't taper all that much proximal to distal,
yeah.
right? So,
yeah.
So
Yeah.
you have a reasonable
Okay.
idea, even from your proximal vessel, what the balloon's going to be.
Are
I
you
think
able
you
to
took
get-
a 4.0
Okay, so we'll take a
approximately,
3.0
right?
NC.
So yeah,
Yeah,
if
we're
you go
taking a
80% of that, a
4.0
30, 325 is going to do a good job.
Yeah, exactly. That's what I'm aiming to do. All right.
Yeah, I mean, well, I think at this point he's just got large segments that are underexpanded there.
It's so crazy how it did not look like that at all on, again, like as we all see every day. The angiogram is such a,
So Ashish, I think
Well
we're
represented.
going to switch over to our subsequent presentations, but we look
Yeah.
forward to coming back to you once you've got a final to show us. Though we, as you point out, we've seen most of it. And
Yeah.
and Joe, just once you're done, let us know, and we'll flip back over to you to see your final result.
sounds good, thank you.
Beautiful case. Thank you very much.
Appreciate it.
Thank you, Ashish. I'm Dr. Srinivas Kumar here. Big round of applause.
Oh,
to
hi
all of
Srinivas,
you.
how are you? Nice
Thank you for all the help extended during the tough times of arrangement and all that. And at night time coming, we really appreciate it, Ashish. Thank you.
No problem,
With
thanks.
you
Yeah,
if you
thank
want us to be back after this presentation.
Yeah, all right, sounds good. Thanks again,
Beautifully
Srinivas. Take care.
executed case.
Yeah, bye, see you. Thanks.
Great. Thank you.
Bye. Thanks again, Sanjog. Thanks. Bye,
See you
bye,
in a few
bye.
minutes.
Bye, Arun. Bye, Arun. Yeah, bye.
Bye, Ashish.